Hello, everyone. Welcome to our Zoom meeting. Today we will have different items in our topics. We will start with the false. When the team is ready, we will start. Thank you, everyone. So the first item will be false in older adults. Dr. Amna will start, and then the other topics will include US health system 101, followed by AI for IMG. Is Dr. Amna here? No. I'm gonna give them a minute or two. In the meantime, do you have any questions? Any updates, Dr. Sabry?
Dr. Nader, how are you? I have just a small question. When we published our researches, how to choose the suitable journal um, for it? Do we have something specific to search about to choose the perfect one?
Thank you for your question. There is a tool, it's called Jane. I can share the screen with you, and it's called Jane Journal Finder. So if you go to Jane Journal Finder, you will find it here. When you click on it, you can put some of the abstract that you are talking about, and it will catch some of the phrases or keywords in your abstract. And if you hit find journal, it will give you a list of journal. Let's say we want to talk about dementia, sleep in older adults, and mobile application, for example, devices, something like that. So if you hit here, it will give you a list of all these journals that will talk some or related to some of the abstract words that you are using. So telemedicine, for example, journal of sleep or dementia, something like that. And here is a journal factor. So impact factor, like the higher, the better. So you go to their website and see what they require, like as far as the fees, for example, the author page where they need to give the manuscript will be in certain ways when you write it, tables, references. So there are a lot of things that you can get from their website and the journal. But this is a way to search for a journal that match your manuscript if you want to publish as an article. Is that clear for you?
Yeah, it's very clear.
Thank you.
Is there anything that's similar when we search for conferences that align for it?
I haven't come across something like that, but usually we target like certain, depending on your interest, certain conferences. If you are interested in family medicine, internal medicine, you can go specific, or you can go in large. For example, there is a American Geriatric Society that will fall into both like specialties. Some applied, or some presented in other conferences like cardiology conferences and so on. There is internal medicine conference that's for the Midwest here in the US, and so on. There is the American Medical Director Association, also some fellows presented there. So there is no a tool that I can say you can use similarly. Thank you.
Thank you very much.
You're welcome. Any other questions or? Dr. Anna, when you are ready, we can start the meeting. Thank you.
Assalamu alaikum. Hello, everyone.
Alaikum
Hello,
salam.
Dr. Nadia.
Hello, Dr. Anna.
Okay, so today I'll be presenting the first topic. Inshallah, I'll be talking about falls in older adults. Just be sharing my screen. Can you see my screen clearly?
Yes, Dr.
Okay.
We can see it. You can go ahead.
Okay. So today we'll be talking about falls in older adults. First, we'll start about the brief. I'll give you a brief introduction, and then I'll talk very briefly about the normal gait and the different factors that form the normal gait. Then we'll go through the risk factors, the epidemiology, and some of the statistics, and then the pathophysiology of why they're more frequent in adults, and then about the important history and physical examination points which you would need to focus on when taking a history from a patient who suffered from falls. And then very briefly about the evaluation and management, and then I'll give you some references for further readings. Okay, so starting off, falls are one of the most common and serious issues contributing to disabilities, especially in older adults. Now, the definition of falls falls are events that result in a person coming to rest on the ground or other lower levels unintentionally, and that's the caveat. It's unintentional, which is not a result of a major intrinsic event. So when it's not a result of a stroke or some sort of illness, or an overwhelming hazard that made them fall. So they just fell to the ground by themselves. Now, it's directly correlated to mortality, morbidity, and reduced functionality, which is why it's very important. Okay, so there are several factors which contribute to normal gait. Those include basically the basal ganglia and brainstem system, the regulation of the muscle tone, and the functional processing of sensory information, the proprioception, or the sensation of position, and other sensations such as vision, hearing, and, as I said, proprioception. So it's a mixture of different parts of the nervous system, the musculoskeletal system. The coordination of these different factors make the normal gait. Now, with aging, adults usually develop wide-based gait and a decrease in gait velocity, the step length. So they usually turn to take shorter steps, and the lower limb strength also decreases with age. And we'll talk about the pathophysiology of why all of these happen in older adults. Okay, now generally speaking, who are at risk, or who is at risk of falling? Older adults children and athletes. Those group of individuals, children we know because they have not developed the coordination of the sub-factors or the factors that we just talked about, the sensory part, muscular part, and the basal ganglia, the neurological part. So children have not developed it well. In adults, those
sorry,
factors,
Dr. Amna.
Yes,
I think the screen is not changing.
it's not
If
changing.
if you can stop the share.
Okay.
Yeah.
Okay, I'll try to share the whole screen. Maybe it will work better. Do you see it now?
Not yet. Yeah, it's
Clear?
yes.
Okay. What about now? Can you see the slides?
I can see the first. Yes, it is changing.
Okay, okay. Thank you very much. Thank you, Dr. Rayan. Okay, so this is the introduction which I went through. Basically, the definition of falls and why it's important, the direct correlation to mortality, morbidity, and reduced functionality. And then here is the slide which I briefly talked in about the different parts that form the normal gait. Okay. So as I was saying earlier, children have not developed those factors to a substantial level, which allows them to have full coordination. Adults have declining functions of those sub-factors. And in athletes, because they usually tend to move a lot, so it makes them more at risk of falling while exercising. Okay, so we will zoom into the important part for us, which is older adults, which is the focus of this presentation. Now, why are older adults at risk? Well, first of all, the functions generally decline with age. And in this case, the functions which form the normal gait, which we talked about a few minutes ago, those specifically also decline in older adults with age. Now, there's also a probability of accumulating medical issues with age, which also contributes to more loss of functions and more loss of muscle mass. And then after that, a lot of medications contribute to increasing the risk of fall in adults. A very famous one and a very dangerous one is benzodiazepines, and generally psychotic or hypnotic medications, and also medications that cause low blood pressure and that can cause dizziness in adults, vertigo, and other issues as well. So it's a mixture of those things: the declining in functions, the medical issues that accumulate with age, and the medications or the polypharmacy that most adults usually are victim of, or not a victim of, but usually because they accumulate a lot of medical issues, they tend to be taking more drugs than the younger population. Now, I'll move quickly through the risk factors. And the risk factors are especially important, not only to assess them when taking a history from the patients, but it's also important to assess them because they can help us navigate the process of preventing falls in older adults. First of all, history of falls is a very major risk factor. Impairment in balance, so people who have disorders, neurological disorders, which, for example, ataxia, or just any sort of disorder that can cause an impairment in balance. Reduced muscle mass or reduced muscle strength also is an important risk factor. Visual problems, polypharmacy, which is defined as taking more than 4 medications. Psychoactive drugs are also a risk factor. Gait difficulty, depression as well, orthostasis or dizziness as well, functional limits, and age over being over 80 years old is also a risk factor. Females usually tend to have more risk than their male counterparts. Incontinence also is a risk factor because can usually lead to having the floor being slippery, which increases the risk of adults falling. Cognitive difficulties, arthritis, also diabetes, and interestingly, pain is also a risk. And it's a very interesting point which we'll I'll explain a little bit further in the coming slides. So again, as a part of the risk factors, I'll briefly go and talk about some medications that are related to falls as well. Those include antihypertensives, because they could lead to the development of low blood pressure, orthostasis, neuroleptics and antipsychotic medication, also sedatives and hypnotics, because they can, in older adults, their response time is generally decreased. So when normally healthy or young person is about to trip or fall, sometimes they'll be able to hold themselves back. But when a patient is taking sedatives and hypnotics, they'll be a little bit more slower. Generally, in adults, their response time in general is slower. And then you would have the sedatives and the hypnotics, which are going to exaggerate the slow responses. Non-steroidal anti-inflammatory drugs are also one of the medications that are related to falls, not necessarily cause, but they're related to falls. Antiarrhythmics as well, such as digoxin. The most important one here should actually be at the front or at the start of this list are benzodiazepines. The use of benzodiazepines in older adults increases the risk of night falls and hip fractures by 44%. And it's generally not recommended to use in elderly patients unless strongly indicated. Okay, let's look at the numbers. What's the epidemiological scene like? So generally speaking, more than 30% of individuals over 65 fall every year. That's a very large number. So half of those falls are recurrent, and this recurrence increases to around 40% at 85 years and above. So these are very big numbers and very big statistics. And that's why it's a very apparent issue in the elderly patients or in older adults in general. About 10% of those falls result in serious injuries. Examples of that are fracture of the hips, other fractures, even traumatic brain injuries or subdural hematomas. So it's also very important because these are very serious side effects. And we know that in elderly patients, the management of those issues become more complicated because they get to get infections from the hospital. The treatment course generally just becomes more poor with age. Now, falls are also the most common accidents in people aged more or equals to 65. And they are a major cause of hospitalizations and injury in this age group. So falls alone are a major cause of hospitalization and injury in elderly adults, in older adults. Injuries caused by falls are associated with increased mortality. Of course, they're associated with the use of ambulance services, social care, hospital care, which really put a huge substantial financial burden on the patients. The risk escalates and the number of risk factors increases. And as we discussed earlier, the risk factors, and I think a lot of older adults really from practice alone, you would notice that a lot of older adults would exhibit at least one or two of the risk factors that we discussed earlier. So as the risk increases, as the number of risk factors they have increases, the risk escalates. Finally, the 1 year risk of falling doubles every year, doubles for every added risk factor. And it starts with 8% with no risk factors at all. And it could increase up to 78% with 4 risk factors alone. Now moving on to the pathophysiology. In the pathophysiology section, we'll discuss a lot of multiple, not a lot, but multiple different pathophysiologies that contribute to falling. An important cause of falls in older adults is the presence of what's known as sarcopenia. Sarco meaning the muscle, penia, a deficiency in the muscle mass or a decrease in the muscle mass, which is age-related loss of muscle mass, strength, and function. Okay. I'll talk in detail about sarcopenia in the coming slide, but now I'd like to talk briefly about the other risk factors. We have some interesting causes such as the postprandial hypertension, in which a person gets hypertension after a meal. It's a non-physiological reason causing falls in older adult subjects. Could probably be due to an autonomic system dysfunction, or could be due to the declining function of the cardiovascular system. Obesity is also linked to an increase in falls, and it could also be linked to the decline in muscle mass and neuromuscular function. And it's just generally difficult for them to move. And then a very important pathophysiological factor is osteoporosis, where older adults can develop rupture of the femoral neck and fractures of the lower limbs, which can be too much. Now we'll focus more on sarcopenia. Sarcopenia begins from the 4th decade. So it starts from the 40s, and it arrives at 50% muscular loss at age 80 or older, especially in inactive older adults. Activity is a very important preventative measure which can be used to counteract this problem. Now, the causes are different, but they include a decrease in what's known as anaerobic or white fibers. There's also a decline in protein synthesis with age, which really affects the maintenance of muscles and cause atrophy of muscles. Also, one of the causes of sarcopenia is an increase in connective tissue and fat within the muscle fibers, replacing the white fibers. There's also some factor of mitochondrial alteration and an increase in free radicals, which also affects the muscle mass and lead to their decline. Now, there's also an increase in the overall inflammatory cell. There's an overall kind of inflammatory environment on the cell. So that also causes a decline in the muscle mass. Now we said earlier, if you remember, that pain is one of the risk factors of falls, and this is a very interesting risk factor. And why is that? Why is that so? So one of the things that could explain this is that cysteine, which is a non-essential amino acid that's used for the synthesis of glutathione, is fundamental for the detoxification of the metabolites of paracetamol. So again, we have paracetamol. Once it's turned into a metabolites in the body, the detoxifications occurs via glutathione and some other amino acids as well, but glutathione is one of them. And glutathione is synthesized from cysteine. Now, in elderly adults with chronic pain, taking acetaminophen is very frequent, which is the Panadol, acetaminophen. Taking acetaminophen in older adults is very frequent. According to studies, the depletion of glutathione and cysteine to clean the liver sites. The patient, for example, doesn't have enough nutrition or not sufficient and good quality of nutrition. The depletion of glutathione and cysteine to clean the liver site causes sarcopenia in the long run. So the pain, again, it's a very long run. It's a very roundabout way. It's a very interesting fact that older adults take acetaminophen, which is justified because the pain decreases really the quality of life for them. They could have an accumulation of the toxic metabolites leading to sarcopenia in the long run. Okay, we'll move on to the history and physical examination. So I'll talk briefly about some of the important points to put in mind when looking or when taking the history of a patient who is either at an increased risk of falls or came with a fall. First of all, as we said, because history of falls is a very important risk factors, we would be wanting to ask about this first. The age is also important because, as we've seen in the statistics, age is a very big contributing factors to the risk of falls. Gender, because as we said, females are more at risk than their male counterparts. Race is also a very interesting thing because falls happen more. Studies show that falls happen more commonly in white ethnicities. Drugs as well, as we discussed earlier. The solitary lifestyle is also an important thing which we need to take about to put in mind while taking the history, because those adults, even if they fall, they would have a very well, after falling, of course, it's very important to get medical attention immediately, so that even if the patient has complications, it's taken care of immediately. So when a patient lives alone, or when older adults live alone, the inability to get immediate medical response is a very serious concern, because it makes their complication worse if they don't get the treatment immediately. If they get a fracture and they can't call the phone or call the ambulance, this is really concerning. So you'd need to ask the patient if they live alone or if they have family support. Okay. Medical conditions that are associated with an increased risk of falls should also be assessed, and those include really various types of conditions, starting with hypertension, moving on to neurological conditions that affect the balance, and so on. Impairment in gait and mobility should also be assessed in the history and examination as well. And immobility or deconditioning as well. So we would need to see if the patient has really bad mobility or is immobile. Poor nutrition as well, because it can cause orthostasis, dizziness, and again, it contribute to the worsening of sarcopenia. Cognitive disorders also are things to put in mind while looking at the history. Impaired vision as well, because impaired vision, the patient won't be able to see their surrounding well, and they would have an increased risk of tripping or falling. Food issues are also very important to ask about, because if the patient has a food deformity, it can also increase their risk of falling, and it's something that can be you can take as a physician. You can take some measures, or at least see some measures that could be taken, even if by occupational therapy. After that, we would look at the environmental factors. So here, we were looking at the patient themselves. Now, when taking the history, we would also consider the environment of the patient. Maybe there is, the environmental factors account for 30 to 50% of the falls in older adults. So these could include poor lighting, and even surfaces or slippery floors. And those are generally taken care of by the occupational therapist and the social workers, who would go and assess the living environment of the patient and provide some measures that could be taken to decrease the risk later on. That's later in the management. Now, why is that so? Because missed steps and slips and trips, it occur more frequently in elderly population, and again, because they don't have as much of a fast reaction time as the younger population. It's very important to look at the lightening and the surfaces and the floors. Okay, moving on to the physical exam. The physical examination will be correlated previous causes of fall and the positive points from the history taking. Whatever positive points, whatever risk factors the patient have, the physical exam should be tailored accordingly to the patient. Now, this could include blood pressure management and looking at the postural changes. Again, looking at the orthostasis, examination of the feet, see if there's any deformity, fracture, a neurological exam as well to see if the patient has any ataxia or has any vision loss or sensory problems. And also manual muscle motor testing to look at the strength. Okay. Now, generally speaking, the screening tests are not really very helpful, and they do not accurately identify the risk of falls, and they're really poor predictors, but I just wanted to give them an honorable mention. There are some tools such as the activity, gait, and balance assessment tool, and the one-leg tandem stance assessment. But again, they're not really helpful, and they're really poor predictors of the risk factor. Okay. Now, another important factor to look into is the activities of daily living. Okay, so patients with difficulties with basic or instrumental activities of daily living are at increased risk of falling. Okay. Therefore, the assessment of those patients' functional status should be completed in details, and those are generally or could be separated into two categories. The first being the assessment of basic activity of daily living, such as bathing, toileting, dressing, feeding, grooming, installation. And then there are the assessment of instrumental activities of daily living, such as the shopping, cooking, and managing the finances, telephone use, laundry, housekeeping, and transportation. So the basic ones and the instrumental ones would assess how well the patient can carry those activities or not. And even after an incident of fall, you will assess if the patient will be able to go back into their normal life, or if they have difficulty, even if they would need help with the activities of daily living. Okay, now moving on to the evaluation. Now we took the history, we did the physical examination, and now we'll move on to the evaluation. Again, the topic is very vast, and there are a lot of causes, so it should be multidimensional and interprofessional, and it should be tailored to the patient's specific needs and the patient's risk factors. Okay, so this will be some general talk about what general evaluation points or management points that could be used. Starting off, we can do a complete geriatric assessment for the patient. We could use some scales to kind of look at the dynamic balance and the walking of the patient, such as the Berg balance scale or the fall efficacy scale, right? To assess the fear of falling or to assess the gait itself. Okay. Other scales can include the 7-minute walking test and the 10 meters walking test. That's used when to look at the gait of the patient, which is really very important to look at. Okay. Again, multidimensional, so there are no standard diagnostic tests. As I said a few seconds ago, based on the history, the physical exam, the lab tests, you would determine really what measurements you take. Or even depending on the history and physical exam, you would be able to determine what lab tests to take. So electrolytes, maybe hemoglobin, the patient could have some anemia that's really contributing to the dizziness, and even the glucose concentration. So this fall incident could be caused by hypoglycemia. Those can help determine the causes of falling, which can include dehydration, anemia, and diabetes, respectively. So dehydration, we could look at electrolytes. Anemia, we could look at the hemoglobin. For diabetes, look at the glucose concentration. Serum vitamin D levels are really essential because vitamin D in general, and I'll discuss later in the management as well after a few slides. Vitamin D supplements are very important, a very important preventative measure of sarcopenia. So starting with a baseline of the serum vitamin D levels can help us establish the supplementation which the patient will, or the dose of the vitamin supplements the patient will need. Okay, now moving on to the management. Again, I reiterated this a lot, but it's really important to know that the management, the evaluation, and even the assessment is multi-dimensional. It's a bit complex, and it depends on the risk factors. So the treatment should be tailored to each patient based on the history and physical exam and the lab results. The management can be complicated. So a combination of interventions such as a medication review to check maybe the patient is taking benzodiazepines for something and they can take another medication, a replacement of that. Giving them an exercise program, which really helps with the management of gait. Giving them vitamin D supplementation, which can really decrease the rate of sarcopenia. And then also a very important home assessment to see if there are any environmental factors that contribute to the risk of falling in this patient. These are the general recommendations. So medication review, exercise program, vitamin D supplementation, and home assessment for the patient. Now, evidence specifies that an exercise program should always be a part of the management as it greatly improves the the gait of the patient, which increases the risk of falling. Treatment of specific conditions should also be carried. So if the patient has cataracts, for example, he should get treatment of that. If he has a problem with the slippery floors or uneven surfaces that need to be taken care of environmentally, that should also be taken care of. Okay. Now looking a bit more closely at the home assessment, the home assessment should be considered for discharged patients from the hospital that have an elevated risk of fall. So even if the patient didn't come to the hospital with an event of falling, and if you're just discharging an elderly patient who has the elevated risk of falling, you're discharging them back home, it would be helpful to consider an environmental home assessment for them. Studies show that home visits by occupational therapists can be instrumental in preventing falls in older adults. Okay, moving on to the exercise program. Now, the exercise programs help prevent falls, right? With no differences between the types of exercise. So it doesn't matter, is the patient doing Tai Chi, are they doing cardio, are they doing normal walking exercises? The type of exercise does not really matter. What matters is that they get an exercise program tailored to them. Okay, so why does it help? Well, the balanced focused exercises, right? Especially the walking heel to toe, the standing on one foot, right? In combination with other coordination exercises, those are the proposed type for fall prevention. So those exercises would train the patient to have a little more grip on their balance, or to be able to better balance themselves. So it's very helpful and it's very promising, increasing the risk of fall. Okay, moving on to the next slide, we'll look deeper at the medication review. Now, for each patient that has an increased risk of fall or that came to the hospital with an event of falling, they should be reviewed. They should have a thorough medication review. Okay, particular attention should be paid for patients receiving 4 or more medications, so those with polypharmacy, and those taking psychotropic medications, especially benzodiazepines. Any unnecessary medication should be discontinued. So, if the patient is taking paracetamol but it's not indicated, they had some sort of an event months ago in which they started taking painkillers and they're just still taking it till now, that should be discontinued. If the patient can have a replacement of benzos with something that has less of risk for their age group, they should have that replaced and so on. Okay, moving on to the vitamin D supplementations. As I mentioned briefly, vitamin D generally is helpful for improved muscle strength and balance. So for the community dwelling or long-term care residents, vitamin D is really essential. And if we look at the statistics, it doses from 700 international units per day to 1,000 international units per day can reduce the falls by 19% after 2 to 5 months of starting treatment, which is really a substantial statistic. Finally, based on the initial assessment, combination of interventions can be used to address multiple risk factors. Examples could include home safety intervention, vitamin D supplement, as I said earlier, and so on. Okay. Now, fall prevention clinics, which really would be a great asset for community care centers. Fall prevention clinics should involve an interprofessional team, so an occupational therapist, pediatrician, physician, neurologist, even for the medication review, pharmacists, and a wide variety of professionals would really need to get involvement in this. Okay, that was a very brief, you could say, an introduction into following older adults. I provided some references at the end in case you want to get further readings for your own benefit. I hope that was clear. Do you have any questions, or maybe you have some experience and want to add something? Please feel free to do so. Can you hear me?
Yes. Thank you so much, Dr. Amna. This is excellent presentation. Anyone with any experience with falls in older adults? Anyone wants to share their stories? So I had a fall, and that was a few years ago. And funny enough, I was talking to one of my students the day before about falls in older adults. And the next day it was snowing here in the area, Michigan. And I was trying to shovel the snow in the morning, and I did not use a good shoe. My shoes were basically flat. So I fell and I broke my arm. I had to go through surgery. So it's important to ask question about the environment, as Dr. Anna mentioned. Look at the medications, look at what you can prevent from happening. And there is a list of medications that usually we are kind of hesitant when you prescribe them to older adults, even young people. They can cause side effects, and you put your patients at risk. So just pay attention to that. Any questions?
Thank you, Dr. Nadia, for sharing your story, and I'm glad you're doing better now.
Yeah, that was a few years ago. Thanks. So we can move on to next item in the agenda.
Assalamu alaikum. Good evening or good afternoon. Hello, Dr. Nader. How are you? Sorry for the delay. I have a technical issue in the beginning, so that's why I wasn't able to moderate from the start. And thank you very much, Dr. Amna, for this great presentation. It was very informative, very rich, and it has added a lot for my knowledge.
Thank you.
We can move now to Dr. Mazin presentation. Dr. Mazin, can you hear us?
Yes, I'm here. I can hear you.
Yes, please. Can you share your screen and start? Thank you.
Yep. Just give me a moment. Can you see the screen?
Yes, we can.
Okay. Okay, so today I'll be discussing the US healthcare system and hopefully help you navigate through insurance, different types of insurance, referrals, and documentation. Okay, to start off, these are the topics that I'm gonna be delivering today. Medicare, Medicaid, the role of primary care physicians and specialists when it comes to insurance. I should say payment models, but yeah, payment models, insurance plans, and prior authorization and referrals, electronic medical records, billing and documentation, patient journey. Okay, so unlike many other countries, the US does not have a universal healthcare system. The healthcare in the US is usually a combination of private insurance and public insurance programs like Medicare and Medicaid. And some of these insurances are subject to variations depending on the state. The public type of insurance, which is Medicare and Medicaid. We have Medicare, which usually people over 65 years old or those with disabilities like ALS, CKD, or certain types of cancer can qualify for. And we have Medicaid, which usually is reserved for low-income people, pregnant women, or children with chronic conditions such as asthma. And usually the cutoff for low income in order to qualify for Medicaid is around $20,000 for an individual, or around $40,000 for a family of four. And in certain circumstances, people can actually be eligible for both. So in the US, the primary care physician serves as the first point of contact for medical care. These are the gatekeepers. They're responsible for management of chronic conditions and coordinating care. And coordinate care between coordinate care to specialists and through referrals and so on. So these are the payment models. Don't get it confused with insurance plans. The payment models are usually differ from different insurance providers. For example, some providers offer high monthly premiums with lower deductibles, co-pays, co-insurance, such as that. Premium is basically the monthly cost of an insurance plan in order to keep your plan active. And deductible is the amount that you pay out of pocket before your insurance starts covering expenses. And you have co-pays, which is a fixed amount that you pay for services such as doctor visits, outpatients, etc. And you have co-insurance, which is the percentage of the cost you pay after your deductible. And the out-of-pocket max, which is the maximum amount you'll pay in a year, after which the insurance covers all costs. So we have four different types of insurance plans: health maintenance organization, preferred provider organization, point of service, exclusive provider organization. So health maintenance organization is one, and it's also the cheapest. Primary care physician, and covers only specialists within the network itself. The network belonging to your insurance provider. And the preferred provider organization is more flexible. It allows you to see any provider, but has higher costs. And you also don't need a referral. And point of service is usually a hybrid plan that combines the features of HMOs and PPOs, in that you don't need a referral it combines features of the HMO and PPO. In that you can, yeah, okay, I just remembered, sorry. And in that you can see out of network providers, but you still need a referral from a primary care physician. And in exclusive provider organization, it's similar to the HMO in that you can only see in-network providers, but you don't need referrals from a PCP. So in most of the insurance plans that we just discussed, you need a referral from your PCP to see a specialist. Additionally, some services like, for example, expensive tests or expensive treatments like biologic treatments, they need prior authorization from your they need prior authorization from your insurance company before they can be done. This process can cause delays in care, so it's important to know how we can manage it effectively. And usually the most common cause of delays in prior authorization is incomplete documentation, in that you don't completely state the indication for the authorization. So the most type of electronic medical records softwares that are used in the US, these are the Epic and the Cerner. They centralize patient information, including diagnoses, treatments, laboratory investigations, imaging, and so on. And they are used to communicate across the healthcare team. They also integrate directly with billing, insurance systems, etc., etc. And they can also be used for billing the procedures and the types of services provided. All of that can be done through the EMR systems. These are the types of billings and documentations that you have to pay attention to. The ICD-10, or the International Classification of Diseases, is usually a set of codes that are used for diagnosing conditions like diabetes, cancer, chest pain, and CPT codes, which is procedural, is for procedures such as surgery, for example, or an office visit for maybe, let's say, a colonoscopy. And the HCPCS codes, these are for services or supplies like medical equipment that have been used, beds, stuff like that. And accurate coding is very crucial for reimbursement from insurance companies. So it's important to understand and document every service accurately. So this is a workflow for all the stuff that we have just discussed. So let's say, let's take, for example, a patient with an HMO insurance plan. He comes to the PCP. He has chest pain, so he comes to the PCP complaining of chest pain. The PCP gives a referral to cardiologist. The insurance requires, for example, let's say the cardiologist deemed that the patient needs a stress test. The insurance is going to require prior authorization for the stress test and indication of why you need the stress test. And after approval, the patient sees the specialist, and he gets the stress test, and this gets documented in the EMR through the CPT, ICD, and the codes that we've just discussed. And then billing is submitted through the codes. So the key takeaways in this lecture is that PCPs are the coordinators of care. They're central in coordinating patient care and referring to specialists. Medicare and Medicaid are vital for elderly, disabled individuals, and low-income individuals. Understanding insurance basics helps navigate costs, while knowing the different plans helps with access to healthcare. And proper documentation is necessary for prior authorizations and insurance reimbursements. Thank you. This is the end of my lecture, and anyone got any questions?
Hello. Hello.
Yes.
Yes, I have a question regarding prior authorization. If the condition is like emergency situation, for example, the patient come with chest pain and he need like stress test, is it necessary to do prior authorization for insurance?
Well, I'm not actually sure on that, but stress test is not usually a test that's needed in an emergency situation, but all the insurance plans in general, if it's an emergency, even if you have an HMO, you don't have to stick to the in-care providers. I hope that answered your question. Yes. Any more questions?
Okay, regarding the electronic medical record system, do you think there is any difference between other type of electronic medical record, like you said, the EPIC and this most common used, and I know other type of electronic medical record. There is the same work or there is a different working?
I'm sorry, I didn't completely get the question. Can you repeat that?
I mean, like electronic medical record system. There is a different name for electronic medical record, like EPIC system, and I know other ones like Athena or a different kind of electronic medical record system. It work the same or there is different in work for this system? They are work the same?
Uh, Basically, in essence, it's supposed to work the same way, but it's just the interface that's different. but it usually does the same job.
Yeah, I will jump here. Yes, I agree with you. And all this EMR, and the idea is to capture the information, the encounter, or the procedure that you perform on these patients, and then document that so that you can submit for the insurance to get paid, basically. They can be used for quality improvement, they can be used for other areas, but the main idea, as mentioned in this presentation, so all of them will do the same, will go through the same sequence or steps. Thank you.
Yeah. Thank you.
Great presentation. Thank you so much. Any other questions?
Thank you, Dr. Nader.
Thank you, Dr. Mazin. If not, we can move on to next agenda.
Thank you very much, Dr. Mazin, and thank you, Dr. Nader, as well for the inputs. Okay, moving to the next agenda will be the AI for medical graduate, international medical graduate. So I just, before starting, I just want to highlight that I wasn't supposed to present for this agenda, but one of the presenter, he has to travel urgently, so that's why I talk on his presentation. So today I'm going to take about artificial intelligence for international medical graduates, in which we are going to explore how AI supports IMGs in research applications and also in interviews as well. Okay, so artificial intelligence first in medical research. We have examples in the medical research. We can use, for example, ChatGPT for drafting systematic reviews ideas. And then I just want to highlight that after we draft the systematic reviews ideas from artificial intelligence, whether it was a ChatGPT or Google Gemini or any other AI tool, we have to validate these ideas by ourselves. Like we have to take the idea and then we will go through the public and the major databases to check the validity of the research idea. Most commonly, we would like to use PubMed or Cochrane, or we can use both of them. Then we have the Rayan AI for screening abstract, and Rayan is basically a tool in which we can insert or import our articles that we are going to screen for the inclusion or exclusion of a such specific criteria based on the criteria that we've developed in the start in the proposal or the possible registration. And then we will go through two phases. The first phase will be the title and abstract screening, and the title and abstract screening is usually done by two separate reviewers, and we would like to let the screening blind on, which means reviewer A will not be able to know what is the decision for this specific articles that have been made by reviewer B, and vice versa as well. So this will be the first stage, is the title and abstract screening. And after that, if there's a conflict between the two reviewer, let's say for article, the first article, the two reviewer, one of them decided to include it and the other reviewer decided to exclude it. So the articles will not move forward and it will not be excluded as well. So in this specific situation, we have two options. We can either um, inform another reviewer, a third reviewer, to make a decision for this specific conflict, whether to include it or exclude it, and it will be settled down. Or we can, if the number of reviewer or the authors is not much more in the research project, we can just sit and discuss until one of the reviewer can convince the other for whether to include or exclude based on his criteria. And then the article will be moving to the next stage, which is the full text screening. And the full text screening will be the same as the title and abstract, but with much more detail. So we have to screen all of the articles starting from the introduction and ending to conclusion, because we already screened the title as well as the abstract. So and then in the Rayan AI, it is notably a free website, but for the additional tools, AI tools that you might need to include in your project, you have to pay a subscription, and they have multiple plans for subscription. But for most of the research project, you will not need to subscribe for the additional fees unless you would like to. Like the basic free plan is enough for you to complete your screening very smoothly. And then we have also the CraftPad Prism with AI adds on for data visualization. And the GraphPad can be used, for example, if one of the fellows are planning to prepare a presentation, abstract presentation in a conference or so, they can use the GraphPad Prism to visualize their data in graphs, in illustrations, and so on. And then we have also the illicit.org for identifying research gaps. And this is basically where you, for example, decided that I'm interested in internal medicine topics, and then specifically in cardiology. So in this website, it will help you to identify the research gaps that have been published by the other researcher in their primary or secondary research. For example, clinical trials that have been done in valvular disease, they will mention in the limitation or in the conclusion that this specific area will need much more research in the future. And this website will help you to identify those gaps for you to be able to generate research ideas as well to conduct them. And then this was regarding the medical research. For the interview preparation, we have ChatGPT for mock interview questions, Gemini as well, but you have to use an adequate and appropriate prompt for the AI to mimic. It will not be as human being for sure, but it will mimic as much as possible for your accent, for your language. Now, accent is not much examined, I think, in the interview, but let's say for your language, for your pronunciation, for your grammars. And then we have also Udly AI for analyzing the tone, filtering the word, and fluency to identify any areas of correction or any areas of concerns that you would like to enhance on. We have also Grammarly and Killbot for improving clarity of responses. Grammarly is basically used for both um, written and speaking grammars issues. And here I prefer to use the subscribe plan. It's and I don't know if they have a free plan, but the subscribe plan is working very well. Google interview warm-up for structured question and answer practice. And then we have also artificial intelligence in ERAS application. Now for personal statement, I just want to emphasize that you cannot use AI for generating the content itself. You will use the AI to enhance the content that you've generated yourself. So for the personal statement, please do write it yourself. and go through your seniors. And I think in here in Pediatric Research Fellowship, mashallah, we have a lot of fellows who've matched in their preferred specialty. So according to your specialty that you are going to apply, you will reach out to them, and they have their emails or their phone numbers in the application to help you in your personal statement. And after you've drafted your first or second draft of the personal statement, you can now move to the AI to enhance the grammars, to enhance the flow, and the grammars as well. So then we have Grammarly for grammar and clarity improvement, as we've mentioned, because Grammarly can be used for both, either for speaking or for writing as well. And the writing plan is much more better as well. Uh, Hemingway editor for consciousness, and Doximity and Thalamus AI-driven residence insight. Doximity is basically a website that will help you for your ERAS application in finding the residencies or the programs that you are interested in, based on some specific filters you would apply. And then we have artificial intelligence for research productivity. For example, we've listed here 4 examples. EndNote with AI tagging for reference management. So EndNote can be used for 2 things. One, it can be used for reference management, like Mendeley and so on. And it can be also used for duplicate removal, which is the main use of EndNote. You will insert your articles that you've exported from the databases, the major databases, let's say PubMed and Cochrane, and then you will insert them. Now, most of the well-recognized journals, they are indexed in both PubMed, Cochrane, and also they might be indexed in Science Direct, Embase, Web of Science. So when you export the articles, you will definitely have a duplicate of the same articles from different databases. So when you insert them and import them in the EndNote, it will help you to remove this duplicate automatically. So it will help you faster to remove duplicate instead of doing it manually. For example, in Rayan that I mentioned in the previous slide, they have the option to remove the duplicate. In the free plan, it will be manual, so it will take time. So that's why I prefer, when you are doing a systematic review and meta-analysis, you take your articles from your database, you decided database, and you insert them, import them into EndNote, because EndNote is free. So there you can remove the duplicate, and then you will take the last articles from EndNote and insert them or import them back into Rayan to improve the productivity. And then we have Cite AI for evaluating evidence strength. Honestly, I have no experience with Cite AI before, so I cannot give my input here. And then we have Scholarly for summarizing papers. This is basically when you are reading research papers to identify gaps or to look for any areas of enhancement or updating. So it will help you for summarizing the papers, to give you an overview of the research paper. If you are going through multiple papers and you are busy, it's very helpful in summarization. Then we have RevMan with AI plugins for meta-analysis. So RevMan is basically used for the meta-analysis or the analysis itself in the systematic review meta-analysis. And it's very easy, straightforward. We can give an overview in the upcoming meetings, inshallah, of how we can use the RevMan for conducting a meta-analysis. And then we have AI for clinical knowledge, for just reading and for reaching our knowledge in the field that we are. For example, we are preparing for step 2 or step 3, so we can use some of these databases up to date, which is I believe they still have the free plan to apply through Better Evidence. If you can Google it, Better Evidence up to date. you will find the link, and then you will apply that I am a third world country resident, and I want to apply for a free account for UpToDate. They will give you, I believe, 1 year plan, full access for UpToDate. And then we have also Ambus, adaptive learning. So also Ambus, they have free library, and as well as they have a subscribed library. The subscribed library is much more better than the free one, and there is a lot of AI tools that you can use in the subscribe tool. Lecturio AI quiz personalization. So Lecturio is basically they are considered a medical library. So if you are planning also to take any exam in the near future and you want a quiz in a specific areas or topics, you can use Lecturio for this personalization. Osmosis, they also have a free videos, but they have a subscribe plan in which it is AI powered case-based learning. AI for networking, we have LinkedIn AI writing assistant for optimizing profiles. This is, I believe, it in the subscribe plan as well. We have Crystal Nose AI for personality-based outreach, and ChatGPT for call email drafting. Job Scan for tailoring CVs to residency programs. So job scans is basically, so when we are applying to a specific job, and I'm not talking here about the residency itself, but in general for the junior doctor who are residing in the MENA region, and they are applying for a specific job, they can use job scan to tailor their CV um, to the jobs that they are applying to, because this will list them high in the top of the applicants. Challenges for international medical graduates who are using AI. So the AI generated personal statement is flagged by plagiarism checkers. So we have to generate our own personal statement and to go through them multiple times with seniors who have been matched, or with much more senior, like they are there as considered as a specialist or either program director, to enhance our personal statement. And then after that, we can use at the end eventually AI just for enhancement of the writing itself, not for generating the content. Over dependence on ChatGPT for answer. And for medical knowledge specifically, I don't think that relying on AI tool at all is considered a good idea, because AI tool is still it is still under development. So we cannot rely on generating medical evidence directly from ChatGPT. Now, for example, if one of the doctor want to use ChatGPT for writing a progress note, writing a referral, this is considered okay after writing himself the notes or the referral, he can use the AI to better improve the fluency and the grammar, but not for generation of the answer in the medical, the drugs, the notes, and so on. Risk of using non-peer-reviewed AI summaries. Also, this may result in some sort of plagiarism or non-reliable, not cited knowledge. So this might result in different knowledge that is already there in the databases, false knowledge in the other way. Data privacy issues when uploading sensitive CVs, and this is very important. Do not apply or do not upload your CV directly into AI tools to generate. So there are now a lot of multiple AI tools for generating CV, and what they're doing, they are asking you to insert your own. For example, they will have sections for personal information, and then then section for your knowledge, like education, and then experience, work experience, and then skills and language as well. So for the personal information, I don't think that it's a good idea to insert them directly into the AI tools. And I don't believe it is the way of a CV that is readable by the ATS. So it's better to write it by your own into a Word document and then convert it into PDF. If you want to enhance the writing, you can use Grammarly after you've generating your own CV. Future of AI in medicine. Example, virtual AI mentors guiding IMGs in a real time, which we are doing here. Dr. Nader, thankfully, he's guiding a lot of fellows into the US residency pathway, as well as a lot of other fellows, senior fellows who have been matched. They are helping the junior ones, helping us in, for example, mock interview, personal statement, and IMG friendly programs and how to identify them. And then we have also the residency program using AI in application screening. I believe they are doing this now, and they can detect that you've used AI to which degree, also by AI. So AI will detect AI. So that's why I would like to emphasize to take care when you are using AI, because it's very noticeable. AI simulated OSCE exams is another example of future AI in medicine, and also global collaboration through AI-powered platforms. Conclusion, AI is a powerful tool that helps IMGs excel in one, research, such as systematic reviews and abstract drafting and preparation for the conferences. Two, interviews for practicing mock interview, fluency improvement, and language enhancement. Then ERAS applications in personal statement, not generating the content, but for enhancing the writing and the grammar and in the CVs as well. But international medical graduate must balance AI use with originality, ethics, as well as personal effort. Thank you.
Thank you so much, Dr. Sabry. This is great and up to date with all contents that are very useful. So thank you so much for sharing these tools. Any questions, addition, any experience, personal stories about this topic? Thank you.
Thank you very much, Dr. Nader. So if there are no comments or there are no questions, we can move to the next session. Presentation with Dr. Rayan. Dr. Rayan, can you hear us?
Yes, can you hear me?
Yes, we can hear you.
Okay, thank you very much. This was very informative. I hope next time you can share how to use Rayan AI and the meta-analysis AI tool that you mentioned. That will be great. So hello everyone. Hello Dr. Nader. My name is Rayan Abdul Wahab. Rayan Mohammed. Today I am going to share how to use the Google form to make a quiz. So I think most of us using Google form in his daily research activity, in making questionnaires and so on. So today we are going to mainly discuss how to improve the use of Google Form for our teaching purposes. So, for example, when we make a quiz, so I'm going to share where we can find the Google Form. When we open our Google, then you can scroll down to the form. Then you have many templates that you can share, or you can make your own from scratch. So before we start, while we are discussing, I just want to share a small Google form. I hope all of you in the comment can go through it before we complete our discussion for teaching purposes. So meanwhile, as I was saying that when we make a Google form, the aim of our Google form, we can make a quiz. When we make a quiz, when we start teaching, or we have a session course that we want to know the percentage of knowledge of our attendee before and after the session, or for example, the performance after we conduct the session, but we prefer it before and after, so you can like to compare their knowledge before and after your discussion of the topic. So for example, if you have a form that you conducted before the session, and then after the session, for example, before the session, the performance in the quiz was 40%, and after the session it becomes 6%, then you can decide it is 60% is what you target, or you wanted to improve it. So you can go to the result section, analysis, the area of deficiencies that we need more discussion, and then you can repeat the next session, repeat the areas that need more clarification. So I share a Google form. It contains a small quiz of 5 questions about radiology. I'm interested in radiology, and I make the question related to geriatric, as much of the geriatric patient complain of a lot of brain hemorrhage and neurological finding that have a clear manifestation in the radiological imaging. So please just quickly, you can answer the question and we can discuss. So we can discuss the result, how to make the question, or how to find the response after the quiz. So before we start, when we make the Google form, for example, as we said here, from the scratch, you can change the form name as, for example, Telegeriatric Research Fellow Assessment, or a quiz form. Then, then we can add a brief description about this. Will be the form for or a quiz for the today's session. Quiz. Then we can move to the more details. First, the most of first question include like this will be an anonymous. It can make it from here. You can make sure which type of question. For example, first question, you can make it a short, like short answer, or yes or no question. Like all of this will be anonymous. All response will be an anonymous response, and it can be used for research purposes. Then you can add agree or not agree. Then you can choose, sorry for the mistake, I'm writing fast. Then you can add like description, go to section. For example, you need that when they said agree to continue to the next section, but when they add don't agree to submit the form, you didn't want the response. So you can make it there. So anyone will choose not agree will automatically go to submission section. When we make a quiz, we can go to the setting, make this a quiz, select this, and you can decide when to have the result. If it is immediately after each submission, this is preferable for multiple answer questions, like what I shared with you in the chat. And immediately you can decide each question have a right answer, and then they can make the total number, and will automatically, when submitted, they get the response and they can review it. Or it is like more have a short answer questions that you want to go back to it, make sure it is right or wrong. And so also you can decide to be later after manual review. And you can choose default question point. It can be one, it can be more. And yeah, that is all. Then you can go to make your question, like example here, you can choose multiple answer, multiple choice, or you can make it a linear, you can make a star rating, you can make it short or paragraph, and you can add a media, for example, like what I did. I add some radiological image, or you can add a video, for example, if anyone is interested in radiology, he can add auscultation finding, add a video from YouTube or so on, and add it, and then he can go to it. So we have, for example, and when we create our question, you can get the help from what we see every day in hospital, or we can use some AI. So I have lecture about the objective of the lecture, and you need like, and then said to AI, I want a questions from this objective. It make it a scenario with multiple choice, for example. Or you can go to question bank and see a lot of questions that is similar to what you are going to discuss during the session, and choose some of them and modify it based on your lecture. So, for example, we have a patient of 75 here. Complain. Sorry. Patient of 7 here. Complain of headache, for example. And then you can add your choice, multiple choice. It is stroke, ischemic, or hemorrhagic. Hemorrhagic stroke, and then hemorrhagic stroke. And then you can add, for example, the photo, and then you can decide it is a required or not. If it is required, so will not submit without it. And then you can choose answer key here, and then it is 1 point, and the correct answer is, for example, is stroke, ischemic stroke. So automatically when or when they are filling the feedback and they choose ischemic stroke, and after submitted all question, they're going back. Here you can also add a question key, answer feedback. You can write why it is ischemic stroke. If it is incorrect, why it is not hemorrhagic stroke. This will appear only to those who choose the incorrect answer, and this will only appear to that who answer correctly. So you can modify your feedback based on their response. So, for example, if they answered incorrectly, you can make a more elaboration about the imaging, what they find, why it is not the correct, or each question that you choose about. Or if they answer correctly, you can make it empty, or you can make more elaboration why it is right. And yeah, that is a question. We can make other question with different style. For example, linear scale. In linear scale, you can set in a scale of 1 to 5 how you describe your knowledge in this area, with 1 being the lowest, 5 being the highest, and just make it also a requirement. Yeah, and that when we make a quiz. And this type of question, we can use it when we want to get a feedback from the attendees, not including like a question, including like a performance feedback on their knowledge and your knowledge during the session. So go back to what I shared with you. This is a telegraphic research fellowship. It is an email. You can make it mandatory or not, and country of resident as well if you want to put. And this we can make it without scoring. Then the scoring comes when we choose the correct answer. Then we have this questions we already made, and then you can, before you share your link, I want to make a peer review, seeing how it will appear to others. Make sure that everything is going the way you want. And yeah, it is okay. Then you can just fill it and submit it or publish it. So yeah, that is what we want. Then we can go to response. So we have a for response here. We have a for response with 2 correct and the average score is 2.75 out of 4. And then you can decide it is good, it is bad, what is you are going to discuss during your session. And then you can seeing how much people answer it wrong and who answer it incorrectly. What is the most incorrectly, like this, the most incorrectly answered questions. And then during the session, you can elaborate more about the areas that most of people answered incorrectly, to make it your session more targeted of what they need. As I was saying, we have other form. For example, when we make a question about, we can make a feedback in which in this I write more. This information will be anonymous and to be used for future improvement and research purposes, agree or not. And then what is your understanding of the session? What is your understanding of sessions? Then you can add more question about what do you mean. And so, where is it? Yeah, that's yeah, in this we write all information will be anonymized, and a participant to the question to withdraw at any time. This is important if you conducted a research, conduct your questionnaire for research purposes, for agreement of the participant to be part of your research. And then this is for, we can use it as a personal improvement. How would you rate your overall quality of the session? How it clears to understanding the content, and you make it personalized based on each course or each session you conduct. Organization of the session. What is your opinion? With 1 being the lowest and 5 being the highest in a scale of 0 to 5. Presentation effectiveness and engagement. Piece of the session, how relevant, and how you would understanding the topic, and how would you relate to other. And you can add a question as you want. If you have any comment, any suggestion, area to improvement, this all based on in your what you are going to discuss and what you want to know from the participants. I think that is all from me. If you have any question, let me know. Thank you.
Thank you very much, Dr. Rayan. Thank you for this great information. Despite the Google Forms are easily, but this is the first time for me to understand it very well. Thank you.
You are welcome. Thank you very much.
Thank you so much, Dr. Rayan, for great presentation as well. Now we can talk about any updates. Anyone wants to share their projects or ideas, questions? Go ahead, please. How far are we as far as mobile application development using the AI, Canva, ChatGPT, or Gemini? Anyone wants to share their experience?
Assalamu alaikum.
Alaikum salam wa rahmah. Dr. Sarah.
Yes, I have updates about my mobile applications. I start late last week. I just choose the name. My applications. I try to do application helping older patient with type 2 diabetes managing their weights. I put the objective and everything with the help of AI. And today I posted in the big group of the telegeriatrics asking who would to create my team and ask other people who is interested. And actually, I have tens of students from here or doctors from here. They would like to join my team. I will go back to through the message and see with them who asked first. I will create my team, and we will start. Inshallah, we will start working on that, putting our objective, and I will do more research, and then uh, make a team. I will make after I make the group with the team. I will discuss with them what the next step, and we will start working on that from this week, inshallah. Thank you so much, Dr. Nadir, for your time and effort and for your great support for all of us. Thank you so much.
Thank you, Dr. Sarah, for sharing, and I wish you good luck. Thanks. Great job. Any other fellows? I know Dr. Saida, she is presenting one of the posters in Minnesota this weekend. So we will hear from her when she's done. Hopefully she will share her experience maybe next week or the week after. Any other comments, any other in general ideas, anything about the program? I know you are busy applying, most of you these days. So I wish you all the best. Dr. Sabry, I put your name and the topic for the week after, not this coming meeting, but the week after, if you are interested to present about Rayan, or if you want to see who feels comfortable to present about how to use it, if that's okay with you. All right, I'd like to thank you all for joining us today in the meeting, and thank you so much for all the presenters for great topics. I hope these topics will help you in your future, and I'd like to thank all those who will watch the recording in the future. Thank you, everyone, and we'll see you next week. If you have questions or any ideas, comments, please reach out. You can email me or send me a text or WhatsApp, call me. I'll be happy to help as much as we can. Thank you. Have a wonderful day, and we'll see you next week.
جزاك الله كل خير دكتور نادر. Thank you so much.
Welcome.
Thank you so much, Dr. Nadia.
Thank you so much, Dr.
Thank you.
Thank you so much.
Thank you, everyone.
Thank you,
Salam.
Dr. Nadia.
Thank you so much.